introduce Dr. Amr Abdelfattah. He's a professor of anesthesia, ICU, and pain in Shams University, and I've met him a few times during discussion of thesis in Castlania and during the exam and the conferences, the pain conferences. He's also the head of the pain and regional anesthesia sector of anesthesia department in Shams University. He will give us a lecture about failed regional anesthesia and how to manage. Dr. Amr?
Thank you very much. Thank you for everybody, and thanks a lot for Dr. Nasreen for this lovely introduction. It gives me a great pleasure to be between you, and thanks for Dr. Saad Mahdi, thanks Dr. Ansari, Dr. Mahmoud, Dr. Fahmi. Everybody is attending this seminar, webinar. I'd like to introduce my lecture. But before we start the lecture, I would like to take the message which came just now from Dr. Mahmoud about a campaign that should be raised in order to increase the awareness concerning the maternal sectors. And actually, during my presence in the United Kingdom a few years ago, I heard this from the hospital that I was there. And they told me when they started to do a campaign about regional anesthesia for maternity in order to endorse the partners to undergo spinal anesthesia or regional anesthesia for their cesarean section, they started to use a campaign which was held by the actors or by mega stars in the community. And this was a very intelligent thing, not to make the doctors themselves are persuading the patients about the regional anesthesia, but in order to make it out of the context. Let's say that there is no intention from the doctors to persuade the patients to go for regional anesthesia. They made it through the stars of the community, and like Lady Diana, she was one of them, and also famous stars, famous singers, famous actors who underwent regional anesthesia to talk about how pleasant they felt while doing the regional anesthesia and having the regional anesthesia for cesarean section. So, Dr. Mahmoud, I really appreciate your idea, and this has to be dealt with by the media, and to make the talk to come from the persons who experience a good results with the regional anesthesia to endorse this for the community. Let's start with I'd like to share my slide, and it's going to be the management of regional block failures. This is a very interesting topic, and I hope it will be helpful for everybody around the table. So our agenda is how the block fails. Number one. Number two, we'll talk about steps to prevent failure, and then we'll talk about spinal anesthesia. Lastly will be epidural anesthesia and how to prevent the failure of the blocks. Prevention is better than treatment. We all know this. And the secret of success for everybody in the whole community, not only the doctors, is to get to work, keep working, don't stop, and this will take you to the step of success. How the block fails? Well, we have a golden standard rules is when you have local anesthetic that missed the target, this will make the block fails. And this will lead to sometimes an incomplete block, sometimes will lead to a patchy block, and sometimes if the local anesthetic missed the target, you will get a rapidly wearing off block. And in the end, if there is no local anesthetic reached to the target area, this will lead to a totally failure of the block. So steps to prevent the failure. Number one, we'll start with our patients. The patient should be consented with for what's the regional block that's going to be done for such a patient, whether this is a parturient, this is an old gentleman who's undergoing a total hip replacement, total knee replacement, a patient for hernia repair. He has to be consented for the procedure, because otherwise the patient might get into a panic attacks that will mimic a failure of the block. We have to trace the contraindications. If you find any contraindication, don't try to persuade the patient for doing the block, and don't attempt to do the block, because this is the first step for having a failure of the block. Explanation is very crucial. You've got to explain, we have to explain for the patient step by step, even if there was no time to explain it, because in the emergency situation, during the performance of the block, gentlemen or lady, I'm going to give you a small stick in the back. I'm going to use a very small needle. I'm going to introduce a bigger needle now. You will feel numbness in the leg if there was no time to explain this in advance. Of course, the mental status of the patient is very crucial. I totally don't like to give a regional block for patients with mentally handicapped or with mental disorientations, because this is one of the causes for failure of the block. Patients with drug addictions are liable for having a failure of the spinal block, and this was mentioned here by a nice study which they found that failed spinal anesthesia in addicts, and they tagged the question, is it an incidence or a coincidence? Where actually they found that because of the large dose of opioids that had been taken by the addicts could lead to a sodium channel blocking effect plus the calcium channel blocking effect. This could also raise the tolerance for some of the local anesthetics that works in the same direction, sodium and calcium channel blocking action. So another thing is to prevent the failure of the block is to choose the correct block technique for the surgical procedure. For example, how about giving an infraclavicular brachial plexus block for a shoulder arthroscopy? Definitely you will end up in a failure of the block. Interscalene brachial plexus block for hand surgery. This will also can give you a patchy block, low density block, or even failure of the block. All like a sole femoral nerve block for a fractured neck femur, and you would like to do a surgery with it, just a femoral nerve block. You might run into a failure of block because you use the incorrect technique for the surgical procedure. Lumbar epidural for thoracic surgeries. Definitely you will need a higher volume, and this will give the patient the adverse effects of a higher volume of an epidural, like low blood pressure, respiratory embarrassment, and these things. Sole tab block for a lower segment cesarean section, and we've been hearing this for quite in the old past years. Like, I can give a tab block for lower segment cesarean section. Well, actually, this is a wrong terminology and a wrong technique for cesarean section, because it doesn't cover the visceral pain. Then we come to the issue of the drugs. The proper dose calculation based on the body weight is very crucial in order to avoid toxicity. If you'd like to use an adjuvant, adrenaline, clonidine, magnesium, dexamethasone, you've got to use the proper dosage and to mix with the drug, and better to be freshly mixed in order to avoid the increase of the acidity of the local anesthetic in the oldly prepared local anesthetic with adrenaline. And concerning the issue of mixing two drugs together, clinicians should be cautioned not to use the maximum dose of two local anesthetics in combination, in the mistake belief that this toxicity is independent and presume that they have an additive effect. This was mentioned in Miller in 1996, and this is still the statement that we use and we focus in while teaching the residents. So it's like giving two beta blockers, giving two vasodilators, giving two diuretics, giving two antihypertensives. So both have a combination and both they have an additive effect. The other thing is the drug. When you have an accidental intravascular injection, make sure that the drug which you are using is having a lower cardiovascular or lower systemic vascular toxicity. Spinal anesthesia. Simply, spinal anesthesia, it has two steps in order to achieve a proper spinal anesthesia. First, you have to puncture the dura properly and to make sure that what's coming out from the needle is CSF. The second thing is an injection in the subarachnoid space. Despite that, failure is not uncommon. Despite that, we can have a proper puncture of the dura and a proper injection in the subarachnoid space, we still can have failure, and this is no shame, actually. It was mentioned that Horlocker and his colleagues in 2006, they reported that they have done a 5,000 spinal anesthesia by him and his colleagues, and reported an inadequate anesthesia to happen despite the fact that this has been done properly in less than 2%. And the Royal College of Anesthetists in the UK suggested that the conversion rate from spinal anesthesia to general anesthesia due to failure should be less than 1% in elective surgeries and less than 3% in emergency cesarean section. Concerning puncturing the lumbar puncture, how can this happen when you have a proper spinal needle, a proper positioning for the patient? Sometimes you will get what we call a pseudo-lumbar puncture. So this means that the CSF that's coming out, or the fluid that's coming out, is not actually a CSF. And this can happen in Tarlov meningeal cyst.
Slide doesn't move, Prof.
Really? Now, is it moving?
Thank you.
It's moving, right?
Yes.
It is Prof Abdelfattah. It is moving.
It's moving, okay.
Yeah.
So what happens sometimes that you get a CSF, a fluid coming from the spinal needle, which actually it's not CSF, and you inject the local anesthetic, and you think that this local anesthetic is going into the subarachnoid space. Well, actually, these patients is having a Tarlov meningeal cyst. Tarlov meningeal cyst is a clear fluid that's coming out because of this is a meningeal cyst, and this will mimic the picture of CSF. If the patient doesn't have a Tarlov cyst, we recommend that a gentle aspiration of 0.5 ml before doing the injection to ensure that this is a CSF coming back in the needle. Fix the needle properly and then do the injection. It's preferable if the syringe is having a lower lock to make sure that none of the drug is going to be missed outside the needle. According to the study by Genuser and his colleagues, he found that the effective dose of bupivacaine used in spinal anesthesia is the ED50 is 7.5 milligrams. So stick to the lower limit of ED50, which is 7.5 milligrams bupivacaine, and the ED95 for surgical success was mentioned to be 15 milligrams. This is according to a study which is in Anesthesiology 2004. One of the causes of failure is the similarity of the ampoules, and we all can have this problem, especially when doing an emergency cesarean section or emergency block. Who can tell that these two cars are not similar? One is Chinese and one is German, but both looks similar. The two ampoules on the right-hand side of the screen look similar. So how to avoid using, let's say, a diluted water, if not atracurium? Sometimes the atracurium in our hospital mimics the bupivacaine, and both are 4 ml. So double check. If you have a colleague, double check. If you have a person beside you that can read, the surgeon himself can read that this is a heavy bupivacaine or spinal bupivacaine, this is very safe for you to avoid missing a drug and having a failure of the block. Sometimes the failure of the technique is based on something anatomically that you don't have a clue on what's going on, or you cannot see it. Let's say that the dura can have a flap valve-like mechanism that will prevent the local anesthetic on the left-hand side. This flap mechanism will lead to the malposition of the spinal needle, so part of the local anesthetic will pass to the subarachnoid space while the other one will pass into the epidural space or in the dural space. Here's another cartoon picture coming from New York School of Regional Anesthesia. If you have this flap-like picture where the local anesthetic, during the aspiration, the CSF will come back during the aspiration, and then during the injection, the local anesthetic will pass into the epidural space, while another part will pass into the subdural space. And this will lead to latency and delayed in the block. Well, the epidural anesthesia, care for contraindications, also how to avoid failures in the epidural anesthesia, avoid patients with coagulopathy, with sepsis at the site of the insertion, patients with infection at the site of surgery, at the site of the introduction of the needle, and also epidural catheter's position is very crucial. This is a diagram which show where we have to put the epidural catheter. If you're talking about a thoracic surgery, it's preferable that you insert your catheter between T2 and T9. In upper abdominal surgeries, it's better to do it in the thoracic region or in the lower thoracic region between T4 and L1. Don't use the lumbar epidural for upper abdominal surgeries. Lower abdominal surgeries like lower thickness cesarean sections and hernia repair, you can do it between T10 and L3, but the best place is L2 and L3. For lower limb surgeries, for fracture neck femur, for total knee replacement, for ankle surgeries, it's between T1 and L3. And this is the best place to introduce the needle, and the tip of the needle should be located at this place. Epidural infusion lines should be clearly identified in order not to be missed with any other lines. And the guidelines say that it's preferable to be yellow in color. Do also a patient monitoring. Look at the blood pressure and the heart rate, saturation. Make sure that the patient's not going into a dilemma of low saturation, low blood pressure, and then this will be the cause of failure because you will turn the patient maybe into a catastrophe by a total spinal or total epidural. Then we come to how to make the epidural safe and effective. These guidelines were mentioned very long time ago and still mentioned in the ASA guidelines till the time being. Do a test dose for lidocaine in the form of 40 milligrams with adrenaline while taping the catheter, and wait for any signs of block or any signs for intravascular problems. Do a slow injection. Use a large syringe with inside a small catheter. Also, what I do like, and I've been using it for the past 25 years, is repainting of the fence. Well, repainting of the fence ensure that if there is a patchy block that happened due to misspread of the local anesthetic in the epidural space, do an injection with a 25% of the initial dose after 15 minutes, and this will increase the density without raising the level. And if you are doing a bupivacaine, do maintenance on the clock, 90 to 120 minutes regularly, and 20 minutes, and make 50 to 75% of the loading dose as your maintenance all the time. Change the catheter position if you have a uni-block or unsatisfactory block or a spotty or patchy block. And this is a very good message which was done by Dr. Gutches. Always show confidence. If you don't show confidence to the patient, this will ensure that patient you have done something wrong, and she will not be satisfied, and she will always be, let's say, having a hesitancy to find confidence with your work. Then we come very important issue. What do you think about spinal after an epidural? What I mean by this is you have given a patient an epidural block, and the patient is having a nice block, and then all of a sudden she started to feel a patchy block on one side, and you started to think, maybe I can give her a spinal block because the epidural is not working after, let's say, 1 or 2 hours of an epidural infusion that's going. This is dangerous because this will lead to migration of the epidurally administered drug to migrate inside the subarachnoid space. And this will put the patient and the doctor in danger in having a total or high spinal. So preferable no spinal following epidural. If you would like to do a spinal first, and then later on you can titrate your epidural for combined spinal epidural, this is the best. But a well-loaded epidural space, and after 1 or 2 hours, you puncture the dura, you will end up in maybe a high spinal block. Now we come to the management of the failed spinal or failed epidural or regional or central neuraxial block. If we have a no block, this will mostly nil of the drug has been delivered, and this could be either The drug has been lost in a space like what we mentioned, a pseudo spinal block, which is a Tarlow cyst, or the spinal needle was outside the subarachnoid space. The hands moved. So this is the importance of doing a barbitage or the just gentle aspiration. Don't repeat the spinal block before 20 minutes to elapse, because this is the time, if you had a spinal migrated drug went to the subdural space, you might get a sensory block with a poor motor block after 20 minutes. If nothing happened after 20 minutes, no sensory block, no motor block, yes, you can repeat the block, you can repeat the spinal, and always show confidence to the patient so she doesn't get panic that you did something wrong. And Dr. Guches also, he said, don't apologize. This was amazing when he did the lecture. He said, please don't apologize. So don't say sorry. Don't say sorry. I have to do for the block again. Just say, I have to do the block for you again because it's not working. And his philosophy behind this, that the word sorry can give the patient an unsatisfactory result and can give patients something like, you did something wrong for me. After 20 minutes, do the general anesthesia. If you don't want to do a spinal anesthesia, again, after 20 minutes, do general anesthesia. If you have an insufficient dense block or insufficient height of the block, and this means that the milligrams of the drug, if it's spinal, didn't reach a proper level, so you can do what we call a Trendelenburg positioning and hip and knee flexion. This will increase the migration of the drug more carefully. If this doesn't help, do an IV analgesia as sedation. And please use only one drug. No need for doing two drugs together, because a bit of this and a bit of that will lead into a dilemma sometimes. So either use fentanyl. I myself, if I find dexmedetomidine is available, I will use dexmedetomidine in a dose of 0.5 microgram per kg, a loading dose over 10 minutes. And then I'll run the patient on an infusion, let's say between 0.2 mics per kg per hour to 0.5 mic per kg per hour. If this doesn't work and doesn't give the patient satisfactory results, I'll turn to a general anesthesia. Unilateral block, this can happen with patients with an anatomical posterior longitudinal ligament, and the unblocked side, if you notice that there is one side not blocked and that this is the site of surgery, in less than 7 minutes, please do just make the less dependent side to be more dependent, and don't repeat the block, please. This is not the area to repeat the block because it is a uni block, because you will add more local anesthetic and the longitudinal ligament is still there. If you have a patchy block, repeat the injection with caution. Preferable, go to IV analgesia or sedation, or do a general anesthesia. If we have a short duration of local anesthetic and the drug type and the dose was behind this, give IV analgesia and IV sedation. And as we mentioned, just one drug, use fentanyl or dexmedetomidine. This will help. And if not satisfactory, do general anesthesia. This is the positional maneuver that we usually resort to. We ask the patient before the motor block to set in, is to do a flexion and of the hip and flexion of the knee. This will help. Concerning repeating the block issue, 15 to 20 minutes, and you have to wait to 15 to 20 minutes in the set of complete failure. Repeat a subarachnoid injection should not be done routinely, and preferable use another space. And with a 25% reduction in the dose of the local anesthetic, as higher concentration of local anesthetic intrathecally can be neurotoxic, and the set of the patchy or low block repeated with caution, as the repetition of the spinal block can have these complications. You have a high spinal block liability, total spinal, hypotension, Coda-Aquinas syndrome from the local anesthetic toxicities, post-dural puncture headache because you're going to puncture the dura twice, in nerve injuries because the nerve, now part of the nerves are numb, so you will not get a feedback from the patient because they will not tell you that I have a paresthesia while introducing the needle for the second time. Epidural hematoma can happen. And this, what we have mentioned, if we have a patchy, low unilateral, always do this with caution. For the epidural, before you do the top-up, always aspirate. Make sure that there is no CSF and there is no blood in order to avoid the catastrophic high spinal block. In the set of the ultrasound-guided regional blocks, practice, practice, and practice, especially for newly evolving blocks like PEC1, PEC2 patients for ultrasound-guided psoas block, ultrasound-guided D blocks. These requires a continuous focused practice in order to avoid the complications. Well, clinical peers for the safety for the patient and for the doctor, as we've mentioned, sedation, avoid the multimodal sedation. A bit of this and a bit of that will lead to a disaster. And usually you have to make sure that you have all the set ready for turning into general anesthesia. Document, and documentation is very crucial in our work because it will keep the medical legal aspect always safe. Explain for the patient during and after, and you have to discuss with the patient during and after why you have to do this. And I would like to thank everybody. I hope I was concise, focused. It wasn't too long for the presentation. Because I wanted to be more concise, just to make, if there is any questions, I'm ready to take. Thank you very much for having me with you, and I'm ready for any questions. Dr. Saad, it's for you.
Thank you very much, Prof. We'll give it to Dr. Prof Nasreen Rifai. She is going to take over. Prof Nasreen. Just start your mic, Prof Nasreen. Dr. Mahmoud, you can take over till Prof Nasreen comes back.
Thank you very much, Prof Abdelfattah. Really amazing lecture about a very important technical challenge that faces practitioners with interest in regional anesthesia. I can't see any questions yet in the question and answer side.
Yeah,
So
Prof Nasreen is back.
Thank you, Dr. Amr.
Okay.
Thank you very much for everybody. Thank you very much.
If you please.
There's a few questions about the combined, one question about combined spinal epidural and the chances of failure of such block and how to manage.
I didn't get this clearly. The question again?
What
are the chances? What are the chances of failure
of combined spinal epidural?
Yes.
And how to manage?
Well, as we mentioned, if there is a failure of combined spinal epidural, this can be from the start. If you've injected the spinal drug or intrathecally drug in an improper place, this will lead to one of the failures. Low volume can be one of the failures. How to manage this? If you find that the spinal block didn't work properly, you have the right to start instituting the epidural slow by slow, let's say by titration. And that's what I like, always titration for the epidurally administered drug because you have a hole now in the dura. So in order to make sure that these drugs are not going to migrate into the spinal canal and lead to a higher level of the block, so titrate, let's say 3 ml of an epidural of a marcaine, 0.5%, followed by 5 minutes later, 5 ml again, or 3 ml again, to make sure that there is an epidural administered drug is migrating to the CSF. Although the chances can be very minimal, but in order to avoid having a catastrophe from the epidural administered drug migrating to the CSF, initiate or start to commence the epidural better than waiting and giving another spinal. So if you have an epidural catheter, start using the epidural catheter at the time.
Okay. May I ask you about the continuous spinal anesthesia?
It's a marvelous technique. Well, we use it. It's a marvelous technique.
Really very nice technique for cardiac patients. We use it a few times for patients with heart failure.
Yes,
continuous spinal.
Exactly. Well, I don't remember the year which were the first data came from Massachusetts General Hospital concerning a patient came with a fractured neck of femur with an aortic stenosis, with a pressure gradient more than 100 millimeters mercury. So it was a tight aortic stenosis, and this patient went for continuous spinal anesthesia using just 0.5 ml followed by 0.5 ml of heavy marcaine with 10 microfentanyl, and it was a dramatic outcome. And the patient left the hospital. I still remember this was mentioned that the patient left the hospital 2 days after the fractured neck of femur was managed, healthy with no complications. So the continuous spinal anesthesia is really a good thing. Especially, you can rely on this in inadvertent puncture of the dura during doing an epidural. So if we have an inadvertent puncture of the dura, if you have an MCQ question, what you do if you have a dural puncture while doing an epidural? What do you do for it in the second level?
Yeah.
You go on a higher level, you put the catheter and do it and take it out immediately and take it out at the end of the surgery before 24 hours to elapse.
I have just a very quick comment, Prof Abdelfattah, on that. It's regarding governance. So as you know, all problems happen because of most of problems happen because of human factors. So there will be a governance issue. So it's about education. So educating the teams that's happening, labeling the intrathecal catheter, and making sure that people deal with it as an intrathecal rather than an epidural. Otherwise, disasters can happen. Like totally.
Sure. Yeah. Sure, definitely. That's why we mentioned that the catheter should be yellow in colors and has to be always labeled that this is an epidural. If it is not an epidural and it is an intrathecal, you've got to label it as intrathecal, and preferable to be written in the documentation in the patient chart and on the patient's body on the tape that's adhesive tape on the patient's body. Yes.
Dr. Amr, I have a question about the valve mechanism. It usually happens, and this is one of the major issues because our needle now, the tip not in the opening not in the tip like all our needle now. So how can you avoid that? How can you avoid it? To bring a CSF, you inject it will fail. How can you avoid this valve mechanism?
Well, I searched in the literature while doing this because this is a very good question, Dr. Yasser. Actually, I miss you so much. Actually.
Thank you.
Since we met. Well, I searched the literature for this actually because this came to my mind. Your question came to my mind. I searched the literature, and according to the literature, it's inevitable. If it happens, it happens because you cannot see it unless you do it with ultrasound guidance. If you would like to do it with the ultrasound guidance, yes, you will find that your tip of the needle with the hole, especially if the needle is an echogenic needle, yes, putting the patient on the prone position or in the setting position and apply the probe, the curved probe, and you make sure that the tip of the needle enters the CSF, and while doing the block, you will find the local anesthetic is passing into the subarachnoid space. Because I know that you're expert in the ultrasound, that's why this came to your field.
Thank you. Thank you, Prof. Thank you very much.
Prof Abdelfattah, I have another question, please. Please. Just see your views about that. So one of the reasons why epidurals sometimes fail is the fact that you put a nicely done epidural in theater for a big operation where the patient really badly needs epidural, and then the patient gets discharged on a high dependency unit or whatever, and then gets missed in a busy unit where people don't go to inject subsequent top-up doses for epidural. Do you think investment in procurement of infusion pumps or patient-controlled epidural analgesia machines would help to tackle this problem? I mean, is it cost-effective to invest in that, or sticking to our current practice of topping up manually would suffice?
In the private, in our private work, we use PCA, either IV or epidural, and it's really good and effective and safe. But first, we educated all the nurses, all the staff about the hazards of PCA and how to monitor the patient and blood pressure and so on. Before starting, we had 1 year educating the staff, the anesthesia technicians and the nurses before starting using PCA.
Thank you,
Dr. Mahmoud. Dr. Mahmoud, your remark is very crucial. It's very important, and I would say that both should be present. The human factor to look after whatever pump you would like. We in Egypt we have both the pneumatic pump, the acufusor. Let's say without mentioning the name of the company, but let's say the pneumatic pump, which is the silicone pump, which is inflated and start to deflate on a fixed rate or on a PCA maneuver. And we have the electrical pump. Cost effectiveness, well, the electrical pump can be used for thousands of patients. But the pneumatic pump, the patient is going to add an extra cost for his bill in order to have the pneumatic pump. The pneumatic pump can be working only for 1 day, and you have to discard it on the next day because it loses its elasticity. Both the human factor and the machine, whether the pneumatic pump or the electrical pump, should be available, whatever, in the high dependency unit, in the usual wards, whether these personal or the human factor should be a nurse, should be a trained physician, should be an anesthetist. I don't mind, so long that he can tackle and call for help if there is any problem. Because a simple problem that can happen is that the patient can have a numbness in the mouth because the catheter started to migrate. And we all know that the catheter can migrate even while the patient stands still at the bed, but while just changing the position, this catheter can migrate into an epidural blood vessel, and he starts to get numbness in the circumoral numbness, ringing in the ears, tingling in the head. So this is a starting local anesthetic toxicity. So the human factor should be present in order to give an alarm or a ring for the anesthetist in charge. And whatever the machine you would like, the pneumatic, the electrically operated one, both are the same. Both are okay. But I do appreciate your remark, and it has to be done in order to fulfill the success of an epidural, because I don't find any rule for an epidural just inserted at the operating room and just taken out while the patient is leaving the operating room for the fear of the complications. You're taking the patient his right from having a pain-free period of, let's say, 24 to 48 hours.
Yeah, thank you very much. Thank you.
You're welcome. Any more questions?
Thank you. We have now 2 hours and a half, very successful night and very pleasant 3 lectures. And I think that's very fruitful. And I will leave the closing for Professor Nisreen Rifai.
I have one question, if you don't mind, for Dr. Ansari, because I didn't have the time to ask him, because his lecture was amazing, really, full of data, full of knowledges. I would like to ask him a question concerning the extubation of a patient who developed seizures in an eclamptic fits. What is the latest guidelines if the patient went in an endotracheal intubation for termination of cesarean section? How much time you've got to elapse before you decide to take the ETT out? Is there any time interval from the last seizure till you decide to wake the patient to avoid another seizure?
Really, in the average about 8 hours, we can leave the patients for 8 hours if the patient's not exhibiting any epileptic, any seizures activity, or any clonus, or any tremors, or hypertonicity. We can, and the other measures also, or other parameters are accepted. Hemodynamic, other signs or other parameters of extubation are adequate. We can extubate.
Thank you very much. Because I used to know that it was supposed to be between 12 to 24 hours. Thank God that it is coming down to 8 hours now.
Maybe
it's something there is recommendation now that even in eclamptic patient, we can still give spinal anesthesia, and it's safe So the Americans said that few years ago, and it's now evidence-based. Once she stopped to have fits, we can go to spinal anesthesia before she has another fit. So they start magnesium sulfate and antihypertensive drugs control the fits, and then take the patient for spinal anesthesia, and it's proved now they don't develop severe hypertension as we thought. So having an eclamptic patient doesn't mean that we have to go for general anesthesia. But these patients will have edematous airway and very difficult intubation.
That's right. Yes, this is right. Yes, I agree with you. No problems with spinal in such situations.
Yes, there's no problem for spinal. Once the patient stopped fits, and even if the blood pressure is still high, we go for spinal.
I want to ask Dr. Amr Abdelfattah, Dr. Amr.
Yes, sir.
About 20 hours is reported because I am not follow it really. Maybe
no, actually, this was during. No, actually, this was during my period of doing anesthesia and an ICU in the past few years. I found that this was the recommendation from the American Society of Anesthesiologists that to keep the patient between 12 and 24 hours from the last seizures in order to avoid having another fits after extubation. So this was 2008. I don't know if there's any change.
After 8 hours, even you have to put the patients under medical supervision.
Yes.
Must be, of course. Must be at least in the ICU for 24 hours.
Postpartum eclampsia.
Yes, exactly.
Really, I want to add something. Really, today I am very happy at this night to see our colleague, Dr. Abdelfattah, Dr. Mahmoud Solani, Dr. Nisreen. Really nice group and nice night. Thank you, Dr. Saad.
Thank you very much, bro. Thank you.
The pleasure is all ours. The pleasure is all ours, please.
Really, I am
having
happy. I return it back
Thank you very much.
To my early.
Thank you. Thank you.
Thank you.
All the best for everybody.
You here, Dr. Abdelfattah, or also in England?
No. I'm in Egypt. No, I'm in Egypt. Yes.
Thank you.